So as a breast cancer expert, can you clear up for us the relationship between estrogen and breast cancer?
Yes, absolutely. There is not one.
Welcome to the Dutch podcast, where we dive deep into the science of hormones, wellness, and personalized healthcare. I'm Dr. Jaclyn Smeaton, Chief Medical Officer at Dutch. Join us every Tuesday as we bring you expert insights, cutting-edge research, and practical tips to help you take control of your health from the inside out. Whether you're a healthcare professional or simply looking to optimize your own well-being, we've got you covered. The contents of this podcast are for educational and informational purposes only. This information is not to be interpreted or mistaken for medical advice. Consult your healthcare provider for medical advice, diagnosis, and treatment. We're really excited. We have a very full day, and we're kicking it off extremely strong with our guest today, Dr. Jenn Simmons. Dr. Simmons, thank you so
Hello.
much for joining us.
It's my pleasure. I'm so happy to be here.
I'm so glad that you're here. We're going to be talking all about redefining breast health. We're going to talk about hormone therapy. There's going to be a lot of fabulous conversation today, I can tell, between
Absolutely.
Dr. Jenn and Mark and myself. But before we get in, I want to just introduce our guest a little bit. So Dr. Jenn Simmons is an integrative oncologist, an author, and founder of Real Health MD. She's Philadelphia's first fellowship-trained breast surgeon, but now she's really focused on that root cause, holistic breast health, everything that we like to do. She also leads Perfection Imaging, providing radiation-free, high-resolution breast screenings. There's so many interesting things to talk about in this field, particularly as you talk about menopausal hormone therapy and the implications if you have a history of or you are a current breast cancer patient. Well, I want to start with something around a very important current event, which is the removal of the black box warning off of menopausal estrogen products. What's your take on that? Can you tell us a little bit about the impact you think that's going to have on women?
Absolutely. So I actually have grave concerns about the removal of the black box warning, not for the reason that you think. As we all very well know, that black box warning should have never been there, right? There was never any data to prove that estrogen in any form has any relationship to an increased risk of breast cancer. But my concern is around the fact that we, as a result of the Women's Health Initiative, as a result of the black box warning, we have two generations of providers who are untrained and undertrained in the area of hormones. And we know that with the practice change, hundreds of thousands of women died prematurely because they were deprived of hormone therapy. We know that millions of women suffered unnecessarily because they were deprived of hormone therapy. But we have two generations of providers who are untrained. So now we removed the black box warning. We got rid of some of the stigma. We are doing our best as providers, as knowledgeable providers, to educate. But most women are going to go to their doctor who has no idea how to prescribe hormones, what to prescribe, when to prescribe it, who to prescribe it to. They just don't know. And the only thing that they're ever trained on is birth control pills. That's all they know. And birth control pills, first of all, should not be used for menopausal hormone therapy. And I can argue that they shouldn't be used at all because they are simply not safe for anyone. And this whole notion that birth control pills are somehow safe, but menopausal hormone therapy is somehow dangerous was so ridiculous. And yet, that is what most providers who are conventionally trained and have not stepped outside of the conventional system believe.
It's such an interesting point that you bring up, and certainly that provider education gap is huge. I was in medical school when WHI was published, so my gyne classes taught lowest dose possible, shortest duration, and it's a complete relearning. But a lot of, you're right, especially GPs, general providers and PCPs, if they're not in a women's health space, their education is probably coming from patients that things have changed because their patients are online looking.
But I think even the gynecologists
Right.
are being educated by the patients because the gynecologists, literally, we think of gynecologists as hormone specialists. They are not. They are surgeons. That is what they're trained to do. They're trained to operate and deliver babies. and their knowledge of the endocrine system is minimal at best. And if there's any dysfunction in the endocrine system, if someone comes with, abnormal periods, abnormal cycles, painful periods, or, any dysfunction in that space, the only thing they're trained to do is write for birth control pills.
Yeah.
That's it. That's the extent of their knowledge. That's the extent of their understanding of the female cycling system. That's a huge problem.
It's a huge problem. Mark, can you speak a little bit, because I know we see this all the time on the Dutch test, like what's the impact hormonally for a woman on birth control pills versus on a menopausal hormone therapy regimen?
Yeah, well, it's a pretty dramatic difference, and obviously there are different types of birth control pills, whether it's the a progestin only, but your classic hormone profile that we see is there's just not a lot there, because you've got all these synthetic hormones, your ethinyl, estradiol, and whichever flavor of progestin happens to be loaded into their birth control pill is there hitting receptors and doing similar but not the same things as your endogenous estrogens, but for the most part, you get a suppression of both the progesterone because you're ovulating, and then the estrogens, and I think sometimes when you use things like mini pills and some of the ones that maybe have less hormones, you still suppress ovulation, but you don't always suppress all that estrogen. And then sometimes with that, you can get, I think, challenges in terms of how the estrogen and progesterone relationship, or I guess it's sort of an odd estrogen, synthetic and endogenous, and then a progestin, how that relationship is sort of plays out. But the classic look is just your female hormones. There's not a huge reason to test those sometimes in those cases, because when you can predict what it looks like, the lab test can sometimes have a little less value. But obviously we're looking at a whole lot more than just estrogen and progesterone. But that's typically what we see from your classic birth control pill, is it just shuts it down.
Yeah. Now, Jen, you mentioned that birth control pills shouldn't be used as an option you said maybe for anyone, but let's talk about perimenopausal, postmenopausal females. There is this comfort in prescribing them because they're used frequently. But the thing that is so amazing to me, that a gynecologist, for example, may be resistant to a menopausal hormone regimen, estradiol patch plus OMP, for example, but they'll put them on an OCP. Can you speak a little bit to just the hormone levels between the differences between those typical regimens?
I don't know that I can knowledgeably speak to that, but I can speak to the fact that we know from the Danish study of 1.8 million women that your breast cancer risk, and let's face it, that is what is on everyone's mind. That's everyone's concern. That was the entire issue with the Women's Health Initiative findings, was that the alarm was sound that menopausal hormone therapy increases breast cancer risk. And if you're going to slot in a birth control pill for Prempro or whatever the other, mainstream menopausal solution was, you're not doing anyone any favors, because we know from that study that your risk of breast cancer is linearly related to how long you take any birth control pill, any hormonal-based oral contraceptive.
Does that start in the reproductive years?
Mm-hmm.
Okay.
And
And it's a direct linear relationship.
for that, is that analogous in birth control pill to the WHI, that the main culprit is the progestin?
It is.
Not the
It is.
ethinyl estradiol?
It is.
Okay.
Absolutely. And because all the OCPs, any hormonal birth control is going to be progestin containing. Right. And so the risk, as we all well know, is directly related to the amount and the duration of your exposure to synthetic progestins.
So as a breast cancer expert, can you clear up for us the relationship between estrogen and breast cancer?
Yes, absolutely. There is not one.
Okay.
Right? So we know from the CEE only arm of the Women's Health Initiative that exposure to even this non-bioidentical CEE decreases your risk of breast cancer. So there is no increased risk of breast cancer according to estrogen exposure. That increased risk is solely coming from the progestins And we have not an abundance of data, but we have good data, over 20 studies of women with a history of breast cancer who have gone on to have hormone replacement therapy afterwards. And there is no increased risk of recurrence with the exception of the HABITS trial, and I can talk about why they saw it in the HABITS trial. There is no increased risk of distant metastasis, no increased risk of death from breast cancer. And in fact, what we saw was quite the opposite. We saw a decreased risk of recurrence and better long-term outcomes, better long-term survival, and for all the reasons that we very well know. Because women who are on hormone replacement after breast cancer and after menopause, because usually it means the same thing, because first of all, 75% of breast cancers happen in the postmenopausal population. And those that happen in the premenopausal population, most of those women are rendered menopausal by virtue of the way that they're treated.
Like you
for
use
their breast
tamoxifen
cancer.
or something like that, for example.
Not so much tamoxifen, but chemotherapy
Okay.
will shut down the ovaries. And many women who have hormone-positive breast cancer, if they get it premenopausal, they're either hysterectomized or they're given something like Lupron and an aromatase inhibitor. So they are essentially rendered menopausal by the treatment. And we know that giving hormone replacement after breast cancer in both populations, in the premenopausal population who is made postmenopausal, or in the women who were diagnosed postmenopausal, there is a survival benefit to them. They have better outcomes when they are given hormone replacement.
Can you help define, you're drawing a distinction between when they have active cancer and then after. So I'm assuming there's not HRT going on during, and for your patients, can you clarify that? And then what is that line of distinction of when you can open up that conversation?
Yeah, it's a great question. So I don't lump it all together. For women with ER-positive breast cancer, I am generally not giving them estrogen during the treatment window when they have cancer, right? So, but that doesn't mean that I'm not giving them progesterone. I am.
I'm excited we're talking about this.
Yeah. And it doesn't mean that I'm not giving them testosterone. I am.
If they're ER positive,
Mhm.
and if they're progesterone receptor positive.
So even if they're progesterone receptor positive, that does not mean that progesterone is making their cancer grow, right? Progesterone and the progesterone receptor and activating the progesterone receptor is anti-proliferative. So I have no problems giving women who are, in the peri-diagnosed period, as long as they're in treatment. I have no problems giving them progesterone, and I have no problems giving them testosterone. We know that testosterone is anti-proliferative in the breast. So my women are not necessarily getting no hormone replacement. I'm just not giving them estrogen during the time that they are in active treatment. Now, what does active treatment look like? For most women, we're talking about 5 years. But there is pretty good data that if they've completed 4 years of anti-estrogen therapy, that there is some benefit to then reintroducing. So when you reintroduce estrogen after a period of estrogen deprivation, and we think the sweet spot is 4 years, there is actually an advantage to reintroducing estrogen in that estrogen will then be cytotoxic. It will be apoptotic to breast cancer cells. And high-dose estrogen can actually be used to treat women for breast cancer after an anti-estrogen period. And the biggest demonstration that we have of this, it was completely unintentional, but if you think about the estrogen-only arm of the Women's Health Initiative. This was the greatest social experiment of estrogen reintroduction because the average age in that study was 63. So most of the women in that study had been menopausal for a significant period of time. And we saw what the reintroduction of estrogen looks like in that group. It means that you're going to decrease their risk of subsequently getting a breast cancer.
I've never heard the study like framed that way, because when you look at it, that's usually discussed as a flaw in the study, but it then also becomes a different type of study in a really interesting way. That's an interesting point.
So it was a completely unintentional finding, but that in effect was what it was. It was taking a group of women who have been postmenopausal for a significant period of time and seeing what the reintroduction of estrogen does in that group. And it is protective.
Before you get, just because it's on my mind, before you get too far from the 4-year, 5-year thing, could you just speak briefly to, I'm assuming when you're saying that, you're talking about systemic estrogen. So what about in that window, vaginal, low dose, vaginal estriol, just to help in that region while you're in that transition? Do you take a little different strategy with that?
I do, but there is a signal showing up in the studies. I don't know that it meets statistical significance, but there does seem to be a signal present for women on an aromatase inhibitor who you give vaginal estrogen to. It looks like they do have a little bit of an increased incidence of recurrence.
Okay.
So I do shy away from that. But interestingly enough, if you take those same women on an aromatase inhibitor and you give them testosterone, they don't have the negative side effects of an aromatase inhibitor. So in those women, I am not so much using, I only use vaginal estriol, but I'm not so much using the estriol in those women as much as I'm using testosterone and progesterone. Sure. But I have no problems, and all the societies have come in support of vaginal estrogen during breast cancer treatment and beyond.
Just to clarify, you said there's a little maybe statistical signal there for vaginal estrogen. Is that a generic estrogen or estradiol or something synthetic or estriol, or is that like what is that?
It's for estradiol because
okay.
none of the studies are using estriol.
Right. Okay.
All of the studies are using vaginal estradiol.
We'll be right back with more. If you're already running Dutch tests in your practice or thinking about it, there's never been a better time to become an official Dutch provider. Why? Because we go beyond lab testing. Our provider community gets exclusive access to clinical education, in-depth report interpretation training, monthly case reviews, and one-on-one clinical support. Whether you're just getting started or looking to sharpen your functional hormone expertise, we give you the tools to grow. Join thousands of providers already making a difference. Visit DutchTest.com today. Welcome back to the Dutch Podcast.
I want to shift gears and talk a bit more about progestins, progesterone as well, because I think most people have come to understand, I think clarifying that estrogen did not increase breast cancer risk is huge. I'm really glad that you spoke to that so poignantly and specifically. I think a lot of providers are still questioning what to do about progestins or progestogens, let me say, really.
Yeah.
Let's look at this as an umbrella term, because the studies like the WHI use synthetic progestins. But I know there are some small observational trials that compare the safety of a bioidentical progesterone, that it appears to be potentially safer. What are your thoughts around that? Because I know the data is still early. Could you speak a little bit and provide some clarity for providers around, like, should they be still worried about progesterone, or is that okay to prescribe?
So I think the biggest problem that we have in this space is that obviously not the people that are here at this conference,
Right.
but most providers do not know the difference between progesterone and progestogens.
So let's clarify that for them.
Right? So progesterone, and they're all synthetic. So I don't want to pretend that we're somehow isolating human progesterone and giving it to our women. That's not what's happening. They're both synthetic. One is a bioidentical molecule. It is the same chemical structure of our endogenous hormone. And one is a mutated structure, for lack of a better word. And the reason why it's mutated is because you cannot trademark a molecule of nature. So there is no benefit to the pharmaceutical companies giving out bioidentical progesterone. And so what do? They change its structure slightly, but that translates into a big change in our body. So it's the difference between our body saying, hey, I recognize this molecule and I know just what to do with it, and a molecule that your body says, all right, it kind of looks like this. Let's try it out here. Let's try it out here. Let's try it out here. So it's binding to different places and having different effects than we intend. So one of the effects is that with all the progestogens, they are overstimulatory. And progesterone is not a stimulatory molecule. Progesterone is like the off button in our body. It's the balancer in our body. It's the calming hormone in our body. So now we have these like Frankenstein molecules, which in some areas it's doing what it's supposed to be doing, but in other areas it's not. In other areas it's hooking onto stimulatory receptors. And so it leads to an increase in breast cancers and unintended consequences. So there is no reason to be using synthetic progestogens except to say that most doctors don't even know, and I won't just use doctors, most providers don't know the difference. And they don't know what they're prescribing or what they're prescribing it for, or the unintended consequences.
I love that you bring that up. And I think the other side of that coin is that progestins, synthetic progestins, do not have some of the intended consequences of why prescribers prescribe progesterone.
Right.
Mark, maybe you can speak to that a little bit because this gets into hormone metabolism, but there are benefits to that biosimilar, bioidentical progesterone when it comes to metabolites having activity that women desire postmenopausally. Can you talk a bit about that? And with synthetic progestins, do you get those same metabolites benefits?
You know, that's interesting because I've never chased down the aloe version of the progestins. That's an interesting question that I shamefully ignorant on. But with progesterone, yeah, when you give it orally, I mean, I tell people often, like when you give it orally, you're giving some progesterone, but you're really giving a prohormone in a certain sense also, in that, you know, the allopregnanolone that really hits the GABA receptor and all of that, you know, progesterone has to get transformed into that. So now in my head, I'm medroxyprogesterone. So that is one loss when you move is, yes, there are progesterone effects that are similar and different, as you said. And then progesterone turns into things that are interesting and have biological effects. And we shouldn't claim to understand all of those because we know allopregnanolone hits the GABA receptor, but there's a whole little family of alpha metabolites that hit that same receptor, and the beta metabolites that are sort of cousins hit it a little bit differently, and there's a little family of that. And then there are the pregnine metabolites, which there aren't very many of them, but there's some interesting research that no one seems to have followed up on, that those have like anti-proliferative effects. And sadly, that there's a Canadian researcher that studied that. I don't know if you're familiar with John Weeb's work, but it just kind of hit a dead end. But all that to say, there are lots of biological effects of, you know, that molecule and why women make it. And so trying to just substitute it, you know, for a synthetic alternative while effective at protecting the endometrium against the effects of estrogen is definitely apples and oranges. A lot of other things that progesterone and its metabolites are trying to do within the body.
Yeah, it's interesting because with menopausal hormone therapy, generally, if you talk to most OB-GYNs, for example, progesterone is only considered for endometrial protection.
Yeah.
And they don't think about those other downstream benefits. But when I look at some of the other data, like for example, TBI data, traumatic brain injury data, progesterone, because of the allopregnanolone, has shown incredible benefit with brain healing, reducing inflammation, brain protection. And when I think about how, at least in our field, providers are prescribing MHT for a much broader purpose than hot flash management. We're looking at whole woman health,
Yes.
prevention. I'm starting to hear some conventional providers say, if you have no uterus, we can still do progesterone. But
Well,
what do you
that's
think
amazing,
about
'cause
that?
I'm not
You're
hearing
not.
that.
Okay, I was going to ask what your experience
So
is.
that still remains a conundrum to them. And I actually have providers calling me saying, like, this woman has no uterus. Why are you putting her on progesterone? And I'm like, God, do you want to read some books? Or?
You need a video that just describes
Yeah.
it. Click this link.
Yeah. And, they say, like, why does everyone need progesterone? And I said, well, where are the progesterone receptors in the body? Because they're not exclusive to the uterus, right? So it must be doing something. But, this goes back to our mainstream medicine is simply hormone ignorant. And they are untrained and undertrained. And a lot of women are going to continue to suffer for a long time. And I think that it's going to take 20 years for this information to become part of mainstream medicine. And I hope it does. I worry about the pharmaceutical industry's influence on medical training and on medical knowledge, because as we all feel very comfortable in the bioidentical space, I don't know that the pharmaceutical industry is going to allow for that information to become part of mainstream education.
It's one thing that I think about is the power of social media and the power it's had to really transform women's health over the last 5 years or so. You've had a big impact on that. So thank you. Because it's a lot of time, thankless time to put content
A lot
out.
of thankless time.
Yeah.
For sure.
So I want to honor that and say thank you. Because what I'm observing, I went to a Harvard Medical School, did like a menopause certification last spring. First time they did it, there were over 1,000 conventional providers there trying to learn. Now, it was still a conventional message, but it was along the lines of NAMS or the Menopause Society guidelines.
Right.
They were at least trying to learn what the update was. But I feel really confident that a large driver for that was patients coming in and asking questions.
Yeah.
And those patients are hearing these things from influencers like you online, physicians who are taking the time to really explain things in a way that they're armed to ask good questions to their doctors. And then the good providers or prescribers are saying, maybe I need to go get some.
Yeah. And certainly that's what we hope happens, that it's driven by the women, but that the providers say, you know what, I really need to go learn about this. Now, the problem is that most providers, if you're in the conventional system, they're just putting their heads down and working. I mean, they're in a terrible, terrible position. At least in Pennsylvania, where I work, most OBGYNs, which, quite frankly, that's where women are going for their hormonal health, they are employed. They're expected to see, 30, 40, 50 patients a day. Their ability to learn a new trick, when are they doing that?
Right.
I don't think that they're spending their nights and weekends doing that. And we all know that's what it takes.
So where do you think patients can go to make sure they're getting a really credible provider?
I think there are a lot of resources out there now. Menopause is definitely having a moment. And social media, as you said, is a big part of that. And so I know that there are several providers out there who are part of this kind of menopause space.
Right.
And they're compiling lists. And I think that, unfortunately, right now, you have to go online and do your research. There are some wonderful training programs out there. I always refer any provider that wants to know more about how to prescribe hormones safely and how to really do a good job with your patient and protect them from a potential breast cancer diagnosis. I think David Rosensweet's program, the menopause method, I think is wonderful. He's been in this hormone space, in this bioidentical hormone space, for 50 years. He's seen everything, done everything, and he has trained thousands of providers, and I hope that his program continues to train thousands and thousands more, because that's really the only way that it's going to change, is when we change practice and change education.
I want to shift gears a little bit and talk a little bit about breast cancer diagnosis. This is another area that you've really honed in expertise and created some new options available to women. Can you speak a little bit to what inspired you to get involved on the diagnostic side?
Well, nothing like your own diagnosis to open up your eyes to what we're doing wrong in conventional medicine, because I started off as a breast cancer surgeon and did that for a long time and was very conventionally trained at one of the top programs in the country, and never thought for a moment that how we were diagnosing, how we were treating was wrong. You know, I mean, when we go through our medical training, we never question whether or not what we're taught is correct or right. We just assume that someone did the due diligence, right? And so it took my own experience as a patient to start asking questions about what we're doing right and what we're doing wrong. And in the area of breast cancer screening, we're getting it wrong.
Okay, talk more about that.
Yeah. So there has never been a study that demonstrates that screening with mammogram increases.
I mean, talk about assumption. I would have just assumed that type of data existed.
Of course. Everyone assumed that data existed, but it doesn't. So every screening program around the world is actually based on the original trial in the UK, where Dr. Michael Baum, who is a surgeon in the UK, was involved in this original clinical trial. It was an invitation to screen trial. And what the findings of that trial, though it was very flawed, what the findings of that trial were that if you screen 1,000 women over 10 years, you will diagnose 4 women out of that 1,000 will die of breast cancer. And if you don't screen with mammogram, 5 women out of 1,000 will die of breast cancer. So the media ran with screening with mammogram reduces the risk of dying of breast cancer by 20%.
Now, let's pause here because, Mark, we'll bring this one to you with your science background. We have like relative risk reduction and absolute risk reduction. This is the exact same problem with WHI.
Yes.
And we see this in science oftentimes. Can you just explain for listeners like what the difference is between those two and how it can impact, like how, especially media in particular, can pick up a story and maybe make it seem bigger or smaller than it is?
Right. Yeah. I mean, I think it's a common thing that when a normal, natural person just hears in passing a 20% increase or decrease, you think of I'm 20% more likely to whatever, when it's like simpler language would be 1 person out of 1,000 is the actual difference there in terms of risk. And it's I think that hits most people's brain without stopping and thinking in a way that greatly exaggerates like what your actual risk is for being the person who not only gets that, but gets it because of the decision around that one thing, which turns out to be 1 in 1,000 people, which is not nothing, but that's definitely a much different picture than thinking that your risks are actually 20% of
Well, so let's bring it back now, because now you're talking about it reduces the risk by 1 in 1,000.
Yes.
And you look at absolute risk.
Yes. And what wasn't reported out of that study was your risk of dying of cancer is the same in both arms.
Wow.
So no overall survival benefit, but there was 1 less person in 1,000 that died of breast cancer. And because of the results of that study, The UK made their national screening program. The United States made their national screening program and just continued on. And no one asked the questions until the Cochrane report. So the Cochrane report was a conglomeration of the Swedish trials, and the Swedish trials were controlled in a way that nothing else was because it's universal health care. Everyone has the same access to care. Everyone has the same exact kind of care. So they divide 600,000 women up. 300,000 get screened with mammogram. 300,000 don't. They get a physical exam or whatever they get with their doctor. And what they find is that the same exact number of women die of breast cancer in each group. And the only difference between them is if you screen with mammogram, you're going to diagnose 20 to 30% more breast cancers.
Is that a good thing?
No, it means that we're diagnosing breast cancer in women who would have never presented clinically.
Okay, so is it somewhat like you think about this like we think about prostate cancer, where we all have cancer cells in our body?
Yes.
You have some, I have some.
Yes.
Because our immune system is always evolving. So
Yes.
you're saying it's catching it so early, the immune system maybe would have cleared it or it never would have become a problem.
It just would have never progressed to clinical disease,
Okay.
right? And it's the difference of dying with breast cancer or dying of breast cancer. And we know from autopsy studies, when we look at women who died of other causes, car accidents, suicides, that kind of thing, if you look histologically at the breast, 1 in 5 women are going to have histologic evidence of breast cancer. 1 in 5 women do not have breast cancer. 1 in 5 women are not dying of breast cancer, right? So, and it doesn't seem that different than the 1 in 8 that we quote over someone's lifetime, but we're talking about 1 in 5 20-year-olds have histologic evidence of breast cancer, right? It's all comers, but 1 in 5 20-year-olds do not have breast cancer. Nothing like that. So when you use mammogram to screen, which is a very unsophisticated tool, first of all, you're going to overdiagnose. And another thing that wasn't reported out of that original UK study was, yes, you will pick up more cancers, but you're also going to have over 100 women out of that 1,000 go through unnecessary testing, unnecessary biopsies. This is not nothing. And when you're putting women through the paces of screening and biopsies, and they're all negative, but you're exposing them to the radiation, to the cost, to the mental toll of
Yes.
having to go through a biopsy, this is very costly. And to some extent, if you screen a woman every year for 10 years, 20 years, 30 years, you are also going to cause some of those breast cancers. So we're using a test that causes cancer to screen for cancer. So it makes no sense. And so I've been very clear on my stance. There is no survival benefit to screening with mammogram. There is no reason to do it. Right? And I don't think that it is responsible or ethical to expose women, healthy women, which is what the screening population is. I don't think it is ethical to expose healthy women to radiation for the purposes of screening. And for a long time, people felt really uncomfortable with that because they feel uncomfortable not screening. And now they don't have to.
This is so interesting because I think the argument you're making, have a lot of really great points. And of course, we had societies say, don't do your self breast exam for a long time. Now that's coming back, but I think part of the
Right,
mammogram
don't be aware
story-
of your body.
Right. But I think you're right. People want to screen, particularly like a woman who was a daughter of a mother with breast cancer, or they had
Yeah.
a sister with breast cancer. There is this desire to be proactive, but there
Well-
were not great options. So talk a little bit about the screening method that you do recommend.
Yeah. And I want to speak on behalf of the providers too, because think about all the providers, especially the ones that are writing for hormone replacement. They feel totally uncomfortable
That makes
prescribing for a woman who's not screening.
That makes
right?
a lot of sense, right?
And even people in our space are totally uncomfortable prescribing without a mammogram because they don't know what else to do, right? So There are 100% safe and accurate ways to screen for breast cancer, and they are what I use to prescribe for both my non-breast cancer population and my post-breast cancer population. So in my non-breast cancer population, I'm having everyone do self-examination. No one is going to ever know you better than you know yourself. And women, despite mammogram and MRI, are still finding their own cancers, okay? So I'm having everyone do self-breast examination. I'm having everyone do the ARIA test, the tears test. And this is an at-home tool to screen for breast cancer. So in 5 minutes, using the fluid in your eye, you can accurately screen for breast cancer. It has a 93% sensitivity for breast cancer.
That's fascinating. It's a protein that's released by the cancer.
It's two proteins that they're actually inflammatory proteins, the S100A8 and S100A9 proteins, that when they're both elevated at critical levels, it's highly correlative with breast cancer. So I'm using that to screen. And if that test is positive, then I'm having people get a QT scan like what we offer at Perfection Imaging, which uses sound waves transmitted through a water bath to create a true 3D reconstruction of the breast without pain, without compression, and without radiation. So safe and accurate and painless screening is here, and we all need to embrace it. We all need to embrace it. And if you don't have a Perfection center near you, if you don't have a QT center near you, you can screen with ultrasound. Because the only thing that ultrasound is going to miss are calcifications, and calcifications in and of themselves are not cancerous or non-cancerous. And the worst that they reflect is DCIS, ductal carcinoma in situ, and I don't even believe that that's cancer. And we have good evidence that 80% of them will not progress. 80%. So for that small 20%, we should be figuring out that they are inflamed and how to overcome their inflammation anyway, right? And that is part of my workup before I'm writing for hormones anyway, is where are you in terms of your metabolic health? How healthy is your environment? Because hormones are ever only the bow on top of the box. And the box is filled with all the foundational elements that we know drive health. And so this safe screening is a very important part of the picture, especially because when you use the ARIA test to screen, you're either going to get a negative result, in which case you know this person's good and they're a good candidate for hormone replacement, or you're going to get a clinically positive result, which says to you, this person has a good amount of inflammation and if they don't have breast cancer right now, they're at risk. And if you do nothing in that person, 11% will have clinical evidence of breast cancer in 6 months. So that test gives you the opportunity to actually prevent a breast cancer diagnosis, which is so amazing. It's a tool and a power that we haven't had as yet. So this ARIA test is going to forever change how we screen for breast cancer. And I just want to quickly mention the Wisdom trial, which the results were just released in San Antonio last week. And what this looked at was, should we be risk stratifying people and developing their screening around that, or should we stick with our annual screening and with mammogram? And what this study showed was that if you risk stratify people, they'll have less mammograms, because in the low risk, they're not doing mammograms at all in that trial until someone is 50 or their risk increases. And then they're getting mammograms every other year if you're low risk. And there were no increase in advanced breast cancers. In fact, there was less advanced breast cancers in that group. And it was called non-inferior to screening every year with mammograms. So we know, at least if we are risk stratifying someone, we know that we are not putting them at increased risk of screening them less, right? Now, I wish that they had a no mammogram arm to compare it to, because we know from the Canadian breast cancer screening study, we know from the Swedish studies that there is no harm comes to these women if they don't screen. But we don't have anyone that brave yet to do that trial.
I know it's like you get criticism for being unethical in our given medical environment.
Even though, again, there is no overall survival benefit to screening with mammogram. But every time you talk about not doing it, people go crazy. And it has nothing to do with science, because the science isn't there. It's all dogma.
Well, this has been amazing, and I have so many more questions. And I wanted to talk about estrogen metabolites and the kind of phase 1 metabolites and their influence. But we're going to have to get you back on if you're open to it.
I would love to.
Because I think there's a lot more to explore here, in particular around some of the nuances. We have a lot of providers that use Dutch testing to pre-screen women around breast cancer risk prior to initiating menopausal hormone therapy. Do you want to just speak briefly to that, Mark?
Well, I mean, I think the risk is the word I always sort of circle around. You look at studies on melatonin and slightly lower melatonin production, there's a slightly higher risk for breast cancer. And if 8-hydroxy, that oxidative stress marker has a weak correlation there, and you start to add these things up, and the combination of the estrogen and progesterone's relationship, and then we know you're making a lot of those 4-hydroxy estrogens, that's a potential problem. But particularly if you're also not methylating well, when you look at the combinations of those things, and that risk starts to stack. And if we can get balance and health and function to your reproductive hormones, and of course looking at cortisol patterns, and people with breast cancer that have flat cortisol patterns, they don't do as well on survival. So there's so many little things that get lit up on the test when you just start talking about things like breast cancer and risk. And that's a whole, other conversation. And so, and this has been really fascinating.
We should do a course, though.
Oh, I'd love that.
Yeah.
That'd be great. And there's
We
just
should
such an
do a
area,
course.
I think in the MHT space, it's come so far. But I think breast cancer, I think about it from WHI. I'd love your point of view, but do you think there are still women being left behind, even in our current
100%.
menopausal strategy? Now it seems like menopausal hormone therapy, more women are being safely cleared, but this group of women who have a risk of breast cancer, I think are still being denied
They're being
therapy.
completely left out of the conversation. If you have a BRCA mutation, if you have a strong family history, and God forbid, if you have a history of breast cancer, you are being denied. Most providers won't even have the conversation with you. And the ones that will are kind of doing it on the down low. There are very few people like me out there saying, hey, I'm having the conversation with everyone. But again, it comes down to, I don't think menopausal hormone therapy is the magic anything. I think it's the bow on top of the box. And we need to be having the same conversation with everyone, regardless of their how they got to you, right? The bottom line is they're suffering. And we don't want anyone to suffer. And it doesn't matter if you have a history of breast cancer or you have a BRCA mutation, these women shouldn't suffer. And as they suffer, their risk for recurrence goes up. Their risk for breast cancer goes up. So we have to relieve their suffering. And that means working with them to mitigate their breast cancer risk, but also help them by giving them hormonal support, especially because we know that it does not increase their risk of recurrence. And the things that are going to increase their recurrence risk are if they're metabolically unhealthy, we know how to help with that. If their environment is unhealthy, and we know how to help with that, right? And at the same time, we can give them the same longevity support that we're giving everyone.
I think one of the things we're not very good at talking about is the risk of nothing. Like we talk about the risk of HRT, but the risk, like men in testosterone, when your testosterone's low, there's a risk of doing nothing.
Yeah,
and with
absolutely.
HRT, and mitigating risk is the whole conversation. And there's risk of action, and there's risk of inaction, and
That's
the
right.
risk of doing it poorly. And it's a great conversation to
Yeah.
Well, thank you both so much for joining today. Mark, I always love when you join on the podcast. And Dr. Jenn, it's been a true pleasure, and we will definitely be in touch to get you back on. There's so much more to talk
Amazing.
about, but thank you so much for just your advocacy in this field, to have such a prominent surgeon with a conventional background, such deep knowledge of breast cancer and a survivor yourself, to be able to speak about this is really transformational.
I had
to our
thyroid, so
community.
I don't want to make anyone think that I didn't have
You
some.
had thyroid cancer.
I had
Okay.
thyroid.
Oh, thyroid. I'm
Yeah.
so sorry. Thank you for
No,
clarifying
that's
that.
okay.
Yeah.
I just, I come from a breast cancer family, and everyone in my family had breast cancer, and my life has been around breast cancer. But what personally opened up my eyes was my diagnosis.
With thyroid cancer.
Mhm.
Thank you. Thank you guys all for joining us today. I'm sure you wish it was going on longer, just like I do. Stay tuned. We have several more podcasts happening today. We'll see you soon.
Thanks for joining us on the Dutch Podcast. Join us every Tuesday for new conversations with leading functional health experts. If you like what you've heard, be sure to like, follow, and subscribe wherever you get your podcasts.